Good afternoon, ladies and gentlemen. Welcome to our webinar. This webinar is dedicated to our case study in the framework of the Horizon 2020 HTX project. My name is Lifang Liu. I will be chairing this session. I'm representing EORTC to lead this case study today. And together with our study team, I'm pleased to present you some key elements of the study and would be very happy to receive your feedbacks and ideas. So as you know, proton therapy is a new radiation technology to treat cancer, aiming to maximize efficacy and minimize side effects of the treatment. Our case study aims to evaluate the benefit of using proton therapy among head and neck cancer patients as compared to the conventional photon therapy. We aim to identify individuals who are likely to benefit from this treatment. We also aim to see from a bigger scope on the society level what would be the added value for proton therapy. So we plan a series of webinars 3 years down the line of the project to enable you to follow us up on the way of development of the study. So this is the first webinar where we wish to present some background information on proton therapy, how this treatment is reimbursed in the Netherlands, and what methodology we use to evaluate the benefit of the treatment. Meanwhile, we have invited patient representatives and colleagues from the health technology assessment sector to give their insights. So we have 5 speakers in this session. After all the presentations, you will be given time to ask questions. So please save your question to the speakers to whom you want to ask. Please kindly notice that you have a question and wait for me to unmute you and proceed with your question. So the session will be recorded if everyone agrees. Thank you for your collaboration. Okay, without further delay on the agenda, I wish to give you the floor to our first speaker, Mr. Enricol Clementel. Enrico is a radiation therapy quality assurance manager at the EORTC. He received his master in physics from the University of Milan, Italy. He worked in molecular imaging and proton therapy for both industry and academia. Enrico worked in imaging analysis, imaging reconstruction, and imaging hardware design. He took up the challenge of assuring high quality of radiation therapy in all EORTC studies since April 2016. So Enrico, the floor is yours. Thank you.
Thank you, Lifang, for the introduction. Thank you, Lifang, for the introduction, and welcome everyone. I'm going to give you a 5 minutes introduction to proton therapy. So it's going to be extremely short, and there's going to be a lot of oversimplification here. So bear with me. So I think we are all familiar with the idea that there are 2 main methods to deliver radiotherapy. Currently, the most common method for delivering radiotherapy is via the use of photons, and this happens using a machine like the one showed here. This is a simple a linear accelerator, which fits into a normal hospital room. It is a machine that can be installed in an existing radiotherapy department and treats tumors by shooting beams of photons at the tumor volume externally. In proton therapy, the principle is still the same, but the type of machine used requires a much bigger space. Here's like a cut view of a proton therapy gantry, and these machines are becoming more and more compact as technology advances. But you have a little red human there for scale. It's more the scale of a bus for the entire system, and you really need to build a new building more than just fitting a machine into an old radiotherapy department. So the upfront costs for protons are quite high, and therefore the topic is important. It's important to know what are the differences between the 2 technologies and why do we pursue protons versus photons. And I am a physicist, and I think most of it boils down to the physics, actually, of the protons and photons interactions with the human body, so with the matter. You can think of photons as behaving, they are particles which have no mass and no charge, and they behave like a cue ball. The most common type of physical interaction at the energy zodiac therapy is called the Compton scattering, which is similar to what you see in the top animated GIF. An X-ray is bouncing actually against an electron at the one of the most outer shells of an atom, and that ionizes that atom and has, as an effect, one of the electrons is liberated, and the X-ray is deviated in its path and cedes part of its energy to the electron. That's a simple interaction to visualize. While for protons, interactions are much more complicated. The protons interact by Coulomb interaction with the electromagnetic fields at a microscopic level. And the result is that they slow down continuously. So they behave like sort of like a bullet in water. And I looked to a simple diagram for explaining this interaction, but it really is very difficult to make one. So I don't have a simple diagram on the right side as I have on the left side. So the protons interact like a bullet in water. What I mean is that they slow down continuously, and most of the interactions are concentrated tightly, densely around the path of the bullet. In other words, the interactions when you have a photon beam are scattered here and there. When a photon interacts, it interacts here and then there, like on a Q table, you can imagine. So these interactions are a little less dense, while a single particle will interact multiple times densely across across its path. So a single proton will interact a lot densely across its path. At the scale of human DNA, a proton can generate a lot more events around the path, and therefore there's a higher probability that we will have a double DNA strand break, which is what we are looking for. We are looking to damage the DNA in 2 or more points in order to impede the cell proliferation later down the line. So there's desirable qualities of proton therapy when it comes to treating tumors. There's at the level 0, let's say there's a spatial desirability. We have spatial good properties when it comes to protons versus photons, and this can be understood by looking at the percentage of radiation dose, so the energy which is deposited in a mass, the percentage radiation dose in the depth of tissue. So you assume you have a tumor 15 centimeters inside the patient's body, and you shoot an X-ray beam. Well, the energy will be deposited this way. The dose of radiation, there's a little build-up region here, and then the dose of radiation will go down as more and more X-rays get absorbed, and therefore there's less and less dose to be released in the tissue. You can see that there is a high entry dose, and then the dose goes down slowly. And when you come to the tumor, you give a relatively low dose compared to the entry dose. So we need to use some tricks to be able to deliver the correct dose to the tumor here. When it comes to protons, instead, you can immediately see that the bulk of your energy is delivered at the end of the path. And not only that, but the proton stop abruptly somewhere in the depth of the tumor. So you can fine-tune your beam and deliver your energy more precisely where you need it. Is a consequence of the fact that the probability of interaction for protons is inversely proportional to the energy of the proton itself. So there is this little diverging curve here. At the entry point, we have a much lower energy deposited, a much lower dose deposited. So when there's a healthy tissue in the entry point, well, we are sparing the healthy tissue much more with protons than with photons, and then we are delivering the tumor dose much more precisely. So spatially thinking, protons are better, have this better property. If you want to visualize this over a patient plan, and I think today we'll see a lot of head and neck plans, so I chose a medulloblastoma patient just to vary. Medulloblastoma is a type of treatment which is a type of disease which is treated by irradiating the full craniospinal axis. Well, as you can see, a photon dose distribution at the top and a proton dose distribution at the bottom. The hottest the color, the higher the energy which is released by the treating beam. If you treat with photons, you see that it is inevitable to have this little energy going on the other side of the tumor. You have a very high dose here, but then at a certain point, you're also treating all the tissue here towards the sternum. And all this tissue is healthy tissue, which is receiving a lower dose than the tumor, but still it's receiving some radiation dose. Instead, with proton, you can see that you don't have this. You stop at the tumor. So these are desirable spatial qualities. But there's also the fact that with the same physical radiation dose, with protons, we kill more cells than with photons. And this is due to several reasons, but mainly we talk about the linear energy transfer of the photons and the protons. So the protons deliver a higher energy per length, and that helps inducing more double DNA strand breaks. And in the end, we say that the protons have a higher radiobiological effectiveness because with the same physical dose, we can kill more cells with protons than with photons. And moreover, this relative biological effectiveness is higher at the end of the path. It's lower comparatively here. So we have the most efficacy at the end of the path, where also we deliver the highest dose. So in summary, we want to treat with protons. We desire to treat with protons in certain cases because they have desirable spatial properties, which allow us to aim exactly at the tumor, but also spare exactly the healthy tissue at the far end of the beam and the entry point as well. And we have desirable radiobiological properties, which make this type of radiation quite effective at killing cells. And this is in 5 minutes why proton therapy is a desirable type of therapy. Thank you.
Thank you very much, Enrico. I know it's very difficult to explain a complex technology in 5 minutes, but you made it. Thank you. Please save questions and go to the end. So without further delay, I would like to introduce you Hans Langendijk. He's a professor and head of Department of Radio-Oncology from the University of Groningen Medical Center. And he's the chair of board of the UMC Groningen Comprehensive Cancer Center. For this major contribution to introduce proton therapy in the Netherlands. So I think people who work in the field, Hans doesn't need further introduction. So now Hans, please go ahead. The floor is yours. Thank you.
Thank you very much. Can you see my slide? Okay. So today, thank you very much for inviting me to give this presentation. I will talk a little bit about what is an NTCP model, because NTCP models are currently used in the Netherlands for selecting patients for proton therapy and also for evaluating the efficacy of proton therapy. And I will come back to that later. These are my disclosures. So Enrico already explained the difference between protons and photons, and this is just another illustration. Here you can see a photon beam, and if you want to hit the target with only one beam, you can see that the normal tissue, which is in front of the target, actually receives more dose than the target itself. And what we normally do in clinical practice is that we combine photon beams from different directions. Here is 2 beams or 4 beams. And in that way, we try to focus the high dose to the target and spread out the dose exposure to the normal tissues. But this normal tissue dose results in considerable radiation-induced side effects, not only during the course of radiation, but also at the long term, and sometimes even 5, 10 to 20 years after radiation. So the proton beam has completely other properties, as explained. You can really target the dose to the tumor and the target itself. And it's not very common that we use only one beam. Also, with proton therapy, we use multiple beams, but you can see at the end, the dose distribution with proton therapy is almost in all cases better and more favorable with regard to the dose to the normal tissues. So today I will go to talk about head and neck cancer, and here you can see an example of a patient with a tumor in the nasopharynx. And here you can see the dose distribution. The high dose is indicated by the orange and red area where the tumor is located. But you can see in the surrounding normal tissues, there is a considerable dose when you do this with FEMAT. FEMAT is the most advanced technology for giving photon therapy at the moment. If you do it with protons, you can see already that we have exactly the same or even a better dose distribution in the target, but the dose to the normal tissues is much lower. You can see in the oral cavity it's lower. You can also see in the swallowing structures located here in this area is much lower, and also in the salivary glands the dose is normally much lower with proton therapy. Now the question is, do those benefits translate into a clinical benefit to patients? And in fact, you can use proton therapy with two main strategies. So the first strategy could be that you use proton therapy to improve local tumor control by increasing the dose to the target. And in that case, the way to validate that is still randomized controlled trials. So that is for two reasons. First of all, if we increase the target dose beyond what we normally do, then we do not know what will be the effect on local control and on survival. So we have to investigate that. And secondly, it's not completely true that you do not get no extra dose to the normal tissues, because if you increase the dose to the tumor, there will always be a part of the normal tissue that also gets a higher dose, even with proton therapy. Only the area will be lower. So in that case, you need to do a randomized controlled trial to see if that is indeed higher than when you do that with photon therapy. So another way to use proton therapy is to prevent complications. And in that case, you do not change the target dose. And there has been now 2 randomized controlled trials in esophageal cancer and lung cancer, indeed showing that there is no difference in local control if you keep the dose the same with protons and photons. But in this case, you try to decrease the dose to the normal tissues. And in the Netherlands, we have now adopted the so-called model-based approach as an alternative evidence-based methodology for selecting patients for proton therapy, but also for the validation. I will come back to that. So the model-based selection can be used for identifying patients who are expected to benefit most from proton therapy in terms of risks of complication. And we can use model-based validation, which can be considered an alternative evidence-based methodology to evaluate the benefit of protons when used to reduce complication risks. So let's first go to model-based selection. How does it work? Well, what we use are so-called NTCP models. That is why it is called the model-based approach. And NTCP stands for normal tissue complication probability risk. And in fact, it's just the risk on a certain complication. You can see it here in the picture. An NTCP model is a prediction model that describes the relationship between a 3-dimensional dose distribution and the risk of a certain side effect. And finally, we have the term delta NTCP, and delta NTCP is the reduction of the complication risk that can be obtained by proton therapy or any other new technology, but now today we talk about proton therapy. So what are the basic conditions to perform model-based selection? Well, first of all, as I indicated in the beginning, the dose to the target should be similar. So the dose prescription should be similar, the fractionation schedule should be similar, and also other kinds of treatment that we add to radiotherapy, for instance, chemotherapy, should be similar. First, the only way to obtain a reduction in side effects is to lower the dose to relevant organs at risk. That sounds very obvious, but in one so-called negative randomized controlled trial in lung cancer, no difference was noted in the complication risks on radiation pneumonitis, which is a complication in lung cancer radiotherapy. But in that study, there was no difference between protons and photons to the lung. So from that point of view, it sounds obvious, but there are still studies that do not take that into account. And then finally, and that's why it's called the model-based approach, that this delta dose should eventually translate into a delta NTCP, which is a reduction in complication risk. And also that sounds obvious. If you decrease the dose, then there will be less complications, but that is not completely true. And this is illustrated here. So suppose we lower the dose from 30 to 20 gray in a patient that is treated with radiotherapy alone. That is the white curve. You can see there is no any benefit to be expected because the risk was already 0%. However, if you go from 70 to 60 gray, also a delta dose of 10 gray, you can see that if you start with a higher initial dose, that the clinical benefit to be expected is around 30% less risk on reduction on complications. Even in this case, if you go from 40 to 30 gray, no clinical benefit to be expected with radiotherapy alone. But if this patient would be treated with concurrent chemoradiation, you can see that the expected benefit is around 30%. So you can see with this relatively simple NTCP model consisting of two factors, the mean dose to a certain organ and treatment modality, you can already individualize and identify patients that are expected to benefit most. So what we have to do is that in every patient, we have to do then a plan comparison. We make a photon plan and a proton plan. Then we get a photon dose and a proton dose. And then we use NTCP models to translate these dose distributions into NTCP profiles. And when we extract them from each other, then we get the so-called delta NTCP profile. And this delta NTCP profile gives you an indication what is the benefit to be expected in terms of lower risks on complications due to radiotherapy. So for head and neck cancer, we have now defined the NTCP models that we are using in the Netherlands for all head and neck cancer patients. And we now use 4 different models, one for xerostomia, two for xerostomia and 2 for dysphagia. And these side effects are the most common late radiation-induced side effects in head and neck cancer radiotherapy, and also have a major impact on the more general dimensions of quality of life. And for each of these side effects, we have models for grade 2 and for grade 3 side effects. So here you can also see the dose distribution parameters that are included in the model. So for patient-rated xerostomia, we use the mean dose to the parotid glands and the submandibular glands. And you can also see 4 different structures, and also there we use the mean dose to these 4 structures. The PCM stands for pharyngeal constrictor muscle, and it's the swallowing muscles that are in the oral cavity and the throat. We did not only include those volume parameters, there are also other parameters included, like baseline xerostomia and baseline dysphagia. And it also depends where the primary tumor site is located exactly. It can be in the oral cavity, but it can also be lower, for instance, in the vocal cords. So how does it work? So here you can see the same patient. Here you can see the swallowing structures that I just mentioned. Here is the oral cavity. Here is the PCM superior, inferior, and the middle. And this is not another understructure. So this is what we already saw, high dose in the tumor region, but quite a high dose as well in the normal structures. And then the question is, here is a kind of other representation of the dose distribution. So you can see here the mean dose in the superior PCM, the middle, etc., which we can obtain with photons. And then we translate these dose distributions into the NTCP profile using these 4 NTCP models. And for instance, you can see that this dose distribution results in a 23% risk on dysphagia grade 2 or higher. And that means that patients are only able to eat soft food or even worse. Sometimes it can even be that they are depending on a feeding tube. So what we do then is we make a proton plan and we do exactly the same exercise. So now you see the green area. These are the dose distributions obtained with proton therapy, IMPT. And also that do we translate into an NTCP profile. And here you can see that the risks obtained with IMPT, which is proton therapy, is much better as compared to what we can do with photon therapy. And then we extract them from each other, and that results in the so-called delta NTCP profile. And that is, in fact, you can consider that as a kind of biomarker for the expected benefit. And in the Netherlands, we decided that for grade 2 side effects, we use a threshold for the selection of proton therapy of 10%. And for the grade 3 side effects, we use a threshold of 5%. So you can see that this particular case would qualify for proton therapy based on the delta NTCP for dysphagia. Here you can see another representation. This is a copy of the National Indication Protocol for Proton Therapy, which has been approved and currently used for all head and neck cancer patients. Now the question is, what kind of thresholds do we use and what does it mean exactly? Now, for instance, if you have a grade 3 side effect, then the threshold that we use is 5% or higher. And if you look to this, is a planned comparison of 50 patients that we did in a few years ago to look at what is the benefit in terms of risk reduction for grade 3 or higher dysphagia. And then you can see if you use the threshold of 5%, that only 24% of the cases would qualify for proton therapy. That are exactly those in which the delta NTCP is highest. So we are now also working on an extension of these delta NTCP profiles. This is an example in which we use the EORTC QOQ head and neck 35, and this is the NTCP profile for photons. And here for protons, and the green color indicates less side effects during the course of radiation. T0 is baseline. This is the 7 weeks during radiation. Normally, the radiation course takes 7 weeks, and this is 5 weeks after radiation. Here you can see, for instance, for painkiller use, it's 84 on a scale of 0 to 100, and you can see it's much lower when patients are treated with proton therapy. And we can also calculate the so-called total toxicity score, and you can see here at the end, at week 12, there is about 50% reduction of this total toxicity score to be expected from proton therapy. But currently we only use these 4 models, so this is something for the future. So what is our first experience in the first 159 patients? So in 10 cases turned out to be not suitable for proton therapy for various reasons, sometimes for psychological reasons, or patients are not willing to undergo proton therapy. For all the other cases, we use this so-called preselection tool, and what we actually do there is we check the photon therapy distribution, and if the NTCPs are already below the thresholds, then there is no need to do a planned comparison, and that is the case in 15%. And then the 75% remaining patients will undergo a planned comparison, and eventually 40% of the patients qualified for IMPT, which is proton therapy. So this selection procedure really tried to identify those patients that are expected to benefit most. So the second thing that I want to highlight is the model-based validation, because you can also use the model-based approach for validating if proton therapy really reduces the complication rates. So how does it work? So what we do is we make a planned comparison. We then get a photon, an NTCP profile for photons and for protons. Then the delta NTCP profile is used to determine if a patient qualifies for proton, yes or no. If not, he is treated with photon therapy and further excluded from the analysis. But if it's the case, then patients can be treated with proton therapy, and then we compare the observed toxicity rates with the expected toxicity rates based on the photon plan and the NTCP, the resulting NTCP model. And that is the comparison made. So if you compare it with the classical RCT, then you compare the observed toxicity rates after proton therapy and photon therapy. With model-based clinical validation, the observed toxicity rates after proton therapy are compared with the predicted toxicity rates based on the photon therapy plan. So this is an example of the first 38 patients in which we had a complete set of acute toxicity. So this is week 3 during course of radiation, 4, 5, 6, 7, and week 12. In the first 2 weeks, we barely see any complications. This is the expected rate if the patient would have been treated with photon therapy. Now, the first thing, of course, that you have to know if this model is still valid if you use this model-based approach. So what we first did is to look in the Photon cohort, that were the 126 patients that were not treated with proton therapy, but with Photon therapy. And here you can see the expected versus the observed rates based on the models. And then you can see they perform reasonably well. There's only a little bit of overestimation of tube feeding dependence when we use the models in this new population, but they were not statistically significantly different. So here you can see then the observed rates, and you can see there is a clear reduction of around 20% during the course of radiation. But what you also can see that the recovery of side effects is much quicker. So after 5 weeks after completion of treatment, there is a 32% reduction of grade 2 xerostomia, that is dry mouth syndrome, as compared to what we would have seen with Photon therapy. And similar results are seen for grade 2 acute dysphagia. And also for tube feeding dependence, we saw that there was a difference. So this is the way that we can do the first analysis on the efficacy of proton therapy to reduce radiation-induced side effects. Another thing that we did is that we compared the expected toxicity rates based on the models with the observed toxicity rates with proton therapy. And what you can see that for dysphagia, they seem to work quite well. But for tube feeding dependence and xerostomia, there appears to be that the observed toxicity rates are lower than we would expect based on the model, so that the benefit of proton therapy is even more than we would expect based on the models. We have to validate it further because these were only 38 patients, and we intend to treat at least 300 to 400 patients before we can say something definitely about the efficacy of proton therapy to reduce side effects. So to summarize, the model-based selection procedure is now clinically used for 3 years almost, and it turns out logistically very feasible. It is time-consuming, and it takes quite a number of efforts, but it's feasible to do. And at this moment, around 30 to 40 of the patients turn out to be eligible, meaning that they meet the thresholds as indicated in the National Indication Protocol. And we also can use the model-based approach for the evaluation. So model validation, I showed you that we also have to validate if the models still work, especially if patients are treated with a new technology. And as you see, the first results indicate that we probably have to adjust or revise the models for proton therapy, which is another technique. And we can use it for model-based clinical evaluation, in which we evaluate whether the rate of toxicities are indeed lower than we would expect when patients are treated with photon therapy. Thank you very much for your attention.
Thank you so much, Hans, for this excellent presentation. We already get questions from the audience, but let's save to the end. So let me introduce J.A.Langendijk as the next speaker. So J.A. is a postdoctoral researcher at the University of Medical Center Utrecht. He is part of the epidemiological method team at the Department of Epidemiology. And his current research is focusing on the methodology for clinical prediction model development, especially in particular for the development of the normal tissue complication probability model, which Hans has mentioned previously. That's the NTCP model within the HTX project. So J.A., please go ahead. Thank you.
Thank you, Lifang. I hope you can see the presentations like this. Okay. Yeah, so I will present to you how within HTX we are doing research on development of the NTCP models. And yeah, this happens in two parallel paths actually. So on the one hand, there's an ongoing systematic review of existing NTCP models. And the idea is that as soon as this review is finished, then the most promising models from the literature will be externally validated from the data within the HTX project. And from that, we'll end up with a set of models. And in parallel to this inspection of existing models, we're also doing methodological research on known challenges with modeling the normal tissue probabilities, which I will also explain a little bit more about. And the final goal is to, from within this two paths, to come to combine them and come to a set of most promising models that would be usable for the validation of the clinical benefit of protons via the model-based selection procedure. So I'll first start with I will discuss the different challenges that are there when developing these NTCP models. The first being multicollinearity. So just a small recap of what is an NTCP model again. So the idea is that based on the radiation plan, so that could be photons or protons, we aim to estimate a probability of, or the risk of, a certain complication. And this is done based on on characteristics of the treatment. So for example, as the mean dosage to certain organs at risk around the tumor. But it could also be take into account clinical variables of the patients. For example, the location of the tumor, or the age of the patients, and other aspects. So for example, I'm taking one example here. So dysphagia, swallowing problems, which is generally, or which could be induced due to damage or radiation damage to the organs related to swallowing. So you can see that here is an example on the right of the organs that are used during, or are close to the gullet, so the swallowing function. And these are the ones that you would not like to use when predicting the risk. So the problem with collinearity, what it means is that you want to know how much the dosage delivered to each organ at risk contributes to the risk of having a complication. And the problem here is that the dosage given to organs that are close to each other is often very similar. So here, on the left, you have a list of organs that are involved and their mean dosages, and you can see that the correlation with these organs, because they are close to each other, is really high. So the correlation of those. And in modeling, this can result in a model where coefficients of the model can be negative. And this means that, if this were to happen, which you can observe, then this would mean that negative increasing dose would reduce risk according to the model, which is something that you really don't want. So this is something that you have to look into, or that we are comparing different methods to address this problem of collinearity, and to So this is one of the challenges we are looking into. So typically, what is done in this kind of setting is that you select just one of the variables or predictors, and then ignore the rest in your prediction model. But here, this is not really desirable, because if you would select one organ at risk and ignore others, that would mean that you assume that the others are not relevant for the complication. So this is something that we are comparing different methods for how to deal with this problem. So the second challenge, methodological challenge in NTCP model development, is missing data. So here I have an image of the available data, or about dysphagia for a set of patients, and over time. So you can see here, this is at 6 months after therapy. This is 12 months, 18 months, and so on. And here you can see that 6 months at 6 months after therapy, around a bit more than 80% of the patients, it is known whether they have complications or not. And you can see that over time, this drops quite quickly, and that after 2 years, it's only 50% of the patients where we know whether they have complications at that time or not. So normally in model development, there doesn't have to be a problem, but if the missingness is not completely at random, so if the missingness is systematic in some way, then this can result in a biased prediction, which is something that you don't want. So we're looking into different methods how to deal or how to appropriately take into account this missing data. And the reason why we know is that it's not completely missing at random is that, so here's another image where you see the same time axis, but here you see the amount of patients with their degree of certain complication. So green means they had no complication at that time. Yellow means they had minor complications. Orange is moderate complications. And you can see here that gray are the missing data patients. And the black here is where it is known that the patient at that time has deceased. So there's also missing data for those cases. So what you can see is that about half of the missing data is actually because patients deceased at the time. So it's so it is clearly related to or it is clearly systematic reason for the missingness. So this is something that we have to take into account appropriately. So the third challenge that we're looking into is the multidimensional toxicity. So Hans already mentioned this as well. So the idea is that it is possible to make or currently what is often done is that NTCP models are developed separately for each time point. So for example, and each complication. So there's, for example, one model which predicts the risk of experiencing dysphagia or severe dysphagia 6 months after radiotherapy. But ideally, you would like to take into account the temporal aspect of the complication as well. And also consider multiple complications so that you would not have a single risk, but have a profile of risk profile for a patient given a certain radiation plan. So this is an example for, and then where you have different complications and different time points, and you have the risk associated with each time point and complication. And then you could make such predictions for radiotherapy or photons and also for protons. And this, you could calculate the delta NTCP, which was relevant for the treatment decision, and then have a delta NTCP profile as well. So this is something that we would like to go, this would be a goal to work towards. And as this multidimensional prediction is also related to the previous challenge. So as you can see here, the amount of missingness, so the gray and the black patients increases quite strongly over time. So if you would want to model the risk of complications over time, you have to consider this missingness as well and incorporate it into your model as well. So we are comparing now with, for example, looking into multi-state models to see if we can if we can model this appropriately. So for the final challenge that was stated is so that's continuous updating, and for that I will first sketch a little bit the context again within which the models are used. So this starts with prospective data registration, and with this from this data the NTCP models are developed, and then these models are applied to a photon and a proton plan, from which the delta NTCP profile is constructed, and then from the delta NTCP profile a treatment decision is made, and then a patient receives either proton or photon therapy, and then after a while of follow-up this patient is again added to the prospective data registration, and it can also be used to validate the current model. But in addition to that, as the number of patients or the data is increasing, it can also be used to update the model. And then there are questions like when would you update the model and how would you update this model? And this is something that we're investigating. And then the reason why you would want to update is, for example, if there are strong changes in the patient population over time, or if there are changes in treatment characteristics over time. It could be that the predicted risk, if you would keep the model constant and not continuously update it, it could be that the actual risk changes while the predicted risk stays the same. So this is what we want to address in this last challenge. So just to summarize, so there's these two paths. So there's the set of we're doing the literature review of existing models, and at the same time we are exploring how to deal with known challenges in development of NTCP models to come to the most promising set of models for the model-based validation. Okay. Thank you very much.
Thank you so much, Tier. I always have admiration for people who can work on these very complicated models. So my compliments. So looking at the time, we are a little bit out of our schedule. So let's move on to Matteo. So today we have the pleasure to have a patient representative in our speakers team. So Matteo, you're from EURORDIS. It's an umbrella organization, patient organization representing 932 rare disease patient organizations from 73 countries. So you are representing a big amount of rare disease patients. And Matteo is patient engagement manager in HTA. So you are working on both national and most importantly on international level to bring patients on the topic. So go ahead, Matteo. We'd like to hear your voice here. Thank you.
Thank you, Lifang. I hope my voice can reach you clearly and loudly. And I know that I told to Lifang I had no slides, but because we are in a webinar, maybe a couple of them can help to follow what I will say to you in the minutes we have ahead of us. So I'm trying to put on a presentation mode. Can you see my screen, my slides? I'm not sure that if the presentation mode, okay. Yeah. Perfect, here we go. So you know that this, I'm talking to the people who are following this webinar today because they are interested not only in head and neck cancer research, but also in what this overall project HTX is doing in the field of head and neck rare cancer. So as this project is about, from patient point of view, to make us take part in the healthcare system that we are preparing for the future in terms of individualized treatment pathways for patients, and in terms of use of big data, artificial intelligence, and machine learning as a base for as a base to the decision-making process. So what is interesting is that in 2018 we had an example in anthropology where we had the community who was the subject or the object of the research participating in the research, and that's the concept we are trying to bring in this project as a peasant organization, so to let the community, who is the, let's say, the target of this research, be part in shaping the research, take part in shaping the research. And that's what patient has been doing since patient advocacy has started in the 90s. So you have here two pictures. One is a real picture, and the second one is a frame from a movie. The movie is 120 bit per minute, where you can see the very first groups of HIV patients around the world organizing themselves to following the progress of the research and talking with the new research sponsors and with the health authorities. Here in this slide, you can see the moment when the head of AbbVie came to meet the patient community because there was a problem of shortages and problem in distribution of new treatments that at that moment reached the market for the first time. So the point from us as EURORDIS is how, as partner of this HTX project, is how to get there. So how to create and realize this involvement of patients in this research that we have been hearing about today. So the first is to educate these patients in HTA and in HTX project methods and objectives. We started to do that since 2009, inviting experts from HTX at the EORDIS summer school, and that will be continue over the next 3 years. Maybe we also with focuses on the different case studies and including head and neck cancer, and following that there will be the creation of materials that can be shared also online as e-learning modules, for example. Secondly, the dissemination of what the project has been doing, and through mainly presentations, videos. At the end of November, we will have the publication of a first introductory video about the HT project. That will be a 2-minute video for the lay public that wants to understand what this project is about, and then of course sharing our views and objectives in collaboration with the other partners in conferences. I know some of the speakers today had already participated in some conferences explaining what the project is about, and also with the scientific coordinators of hospitals and center of reference throughout Europe. And of course, after training and dissemination, we have the properly speaking engagement, so with group of patients visiting the partners of the project and trying to create groups of patients on the model of what we call in our let's say in our dictionary a community advisory board or a patient pool. You can choose the term that you want in these 3 disease areas, and one of which is of course head and neck cancer. And here in the picture, you can see the visit of some patients from the EURORDIS HT task force to one of our partners, the Oulu University Artificial Intelligence and Robotics Department. And how to get there? Indeed, we have 2, let's say, pathways. First, to reach out to all those patients who have been trained, of course, through the EURORDIS summer school, but also through other programs. I know that UPAT is a very well-known program. The UNET training is already well known across the borders, and also what we have been starting to do this month in November, to reach out to those EPAGs, patient advocates, who are working really, let's say, that these EPAGs are groups that are, let's say, embedded in the hospitals which are part of the European reference networks. So we started to reach out to those groups, and there is an Italian organization and an Italian representative and an English one who are part of this, let's say, group in the EUROCAN reference network of hospitals. And there are also patients in France and in Hungary who we have contacted to create this kind of little group of patients who are both experienced in the management of their own disease, in the treatment available today and upcoming in their own diseases, and which are also knowledgeable about HTA, to indeed create this synergy between the HTA expert project experts and the patients, and to let's say start this dialogue in a fair, organized manner, which is the most important for us, in order to first recognize the role of patients, secondly to make the participation of patients easier and more effective through, let's say, a well-organized procedure and framework. That's why we have all these names. Community Advisory Board is a name for this kind of organization, and in order indeed to feed the work of the experts with all the input that patient can share about which population, for example, for which population is harder to manage this kind of side effect, or which subgroup is more, let's say, for which subgroup it is easier to go for one therapy compared to the other, what they think about the dose dose of radiation in different solutions, or which are the endpoints or the relevant outcomes they expect from a treatment compared to the other, which population is more, let's say, intolerant to one therapy compared to the other. These are all interesting input that patients can give, knowing that patients are there first to learn from the project expert and then to give their feedback, and that's the way this exchange can be done in our views, and that's why we hope this exchange can be carried out throughout the next 3 years of the project, thanks to the work we are doing. I stop the sharing, and I thank you for the time and for your attention, and I hope I can reply maybe some of your questions if you have some.
Thank you so much, Matteo. Great to hear that you bring patients on board of our case study. And I think in the future, we will have more interactions on these specific points that you have addressed. So we actually had a planned final speaker, but due to a personal accident, she cannot be here. So we give her a miss this time, but we have opportunities in the next webinars to bring her on board. So looking at the time, we only have 2 minutes left. So I'm just choosing some burning questions from the audience to ask. So I received many questions, and most of them are for Hans. So Hans, get prepared. So may I ask Mr. Ulrich Ruther to ask question to Hans? Thank you. Please unmute yourself and speak out. Thank you. Hello, Ulrich Ruther. Please unmute yourself. Yes, you are unmuted, and please speak to your microphone, and then we can hear your question. Hello? We cannot hear you yet.
Lifang, this is Wim. I think
Wim.
that Hans already responded to his question on the chat, as far as I can see.
Okay.
Yeah, I can just mention it. So the question was, and it had to do with the tumor. I will repeat the question. The question was whether some tumors would not be suitable for proton therapy because they have a more spreading growth pattern, so that you would miss a part of the microscopic tumor extension because the dose is more confined to the target. So in that regard, I think it's important to mention that that is not the case. And so first of all, it's very difficult for patients who have a tumor which is still inside you to determine exactly the growth pattern at the edges of the tumor. So that is very difficult. So actually what we do is the same as the surgeon does. So if he sees a tumor, he does not only excise the tumor, but also takes a margin of 0.5 or 1 centimeter healthy tissue surrounding the tumor to be sure that also microscopic tumor is removed. And actually radiation oncologists do the same. So we delineate the tumor, and then we take a margin of 1 centimeter surrounding the tumor, and that is the area that will be treated with high dose radiotherapy. So we take into account that there might be microscopic tumor spread beyond the tumor that we can see on the imaging.
Thank you, Hans. So we are 1 minute overdue. So I would like to close this webinar. And if you have further questions, please feel free to reach me out. Then I can transfer the question to Hans or other speakers, Theo and Matteo. And I would like to take the opportunity to thank you very much for attending this webinar, especially in the Belgian and French national holiday. But as I said at the beginning, we are planning a series of webinars to report to you our progress on the case study. So please keep on following us, and we'd like to keep in contact with all of you. Thank you very much, the speakers and the audience. Have a nice day further. Goodbye.
Thank you.